Hi, everyone. My name is Gabrielle Altit. I'm a neonatologist at the Montreal Children's Hospital, and I am here today with Dr. Surya Sahatsarungsi, who is a fellow in neonatal hemodynamics at McGill University, and together we have prepared some slides regarding basic cardiac point of care ultrasound. And these slides are meant for pre-conference workshops in order to have prepare some of the material before coming in for some of the hands-on stations. So I will be sharing my slides. Perfect. So it's a pleasure to present today. No disclaimer relative to this presentation, and we'll talk about some of the common targeted neonatal echo or common cardiac POCUS or echocardiography views, and some of the corresponding measurements you'll be able to find on the website, but we won't necessarily address them today. So I want to remind you that there are guidelines that are out there. And these guidelines are published recently in 2024. And you follow the QR code, you'll be reaching the website of the American Society of Echo, both for the guidelines on how to perform targeted neonatal echo and cardiac point of care ultrasound in the context of neonatal intensive care unit, as well as if you're more within the field of cardiology, some of the information regarding a comprehensive pediatric transthoracic echo in the context of neonatology and pediatrics. So we'll go with the common views, and some of these slides will be available to you so that you're able to go back and study from them before you are actually going to practice for the hands-on stations. The first one we'll talk about is the parasternal long axis view. Why parasternal long axis is that it's typically the probe is situated along the parasternal area. So the sternum here, you're around the sternal area, almost where you would put your stethoscope to listen to, I guess, some of the AP area, aortic or pulmonary valve area. And then typically the probe will be placed in a way that usually the marker of the probe is oriented towards the right side of the chest of the patient, which will delineate the heart along its long axis. Why long axis? Because we have the long axis of the left ventricle. You can see the mitral valve and the left atrium, and you can see that there's fibrous continuity with its usual outflow tract, which is the aorta. You can perceive a portion of the interventricular septum, which is obviously a complex 3D structure. Here we're only seeing one of the segment, and we see a bit of the right ventricle closer to its outflow tract. The probe can be oriented more perpendicular to the chest in order to go and get a cut that is obtaining the information more posteriorly, or you can try to fan it out towards more of the interior chest, which is basically the fan going towards the skin, providing you information on more of the interior structures. And so as you go more posteriorly, what you see is the inflow portion of the right ventricle, as well as the right atrium. And eventually, as you go more anteriorly, one of the most anterior structures is actually the right ventricle, its outflow tract, the pulmonary valve, and eventually the main pulmonary artery. Okay. So we will talk about the different views now looking at echo examples. So here's an example on the baby. You can see that the nipple line is around here. You can see that the suprasternal notch is around here with kind of the neck area. And really the probe is typically around the midway or slightly a bit closer to the chin actually, in order to obtain the image of the long axis of the heart and the parasternal zone. Now, this is not a rule. Obviously, babies will have various cardiac motions in the sense that if your lungs are taking space, if you have CDH, if you have intra-abdominal pressure that's very high, there might be some shifts of organs, and sometimes your probe might not be here and it might need to be adjusted in order to get the adequate view. So these are kind of like general anatomical landmarks, but will need to be adapted depending on the patient. And so Typically, for this particular view, the marker is towards the right side of the patient. It will appear by convention in the targeted neonatal echo world with the marker on the left side, on the right side of the screen. So whatever is towards here will appear here, and whatever is towards here will appear here. Hence why the left ventricle is here, because this portion is kind of facing the left part of the patient. So we have the left ventricle. We have then the mitral valve with the anterior mitral valve leaflet and the posterior mitral valve leaflet. And then eventually you get the attachments towards the posterior wall of the left ventricle. You can see that you have the left atrium, then eventually the left ventricle, and then you have the left ventricular outflow tract with the aortic valve, and eventually you get the ascending aorta. And on top of it, which is closer to the probe, so more anterior to the chest, you get the RV free wall and the right ventricular outflow tract. So this is an example on the actual echo. So again, the marker is here. You get the right ventricle, the interventricular septum, the left ventricle, the posterior wall of the left ventricle. And then you get the two leaflet of your mitral valve that you can see flicker as the left atrium is emptying into the left ventricle. The left atrium will empty into the left ventricle during diastole of the left ventricle, which means during the filling phase of the left ventricle. And typically you will get a passing filling phase, which means that the left atrium will empty into the left ventricle as soon as the mitral valve will open. And towards the end of ventricular diastole, you get a bit of that left atrial kick that will send a bit more blood into the left ventricle. And you can actually see this leaflet flicker twice, once when it opens the first time and a second time when it gets this kind of blood flow coming from the left atrium. And you can see that the left atrium size is getting smaller as it is emptying into the left ventricle and getting bigger when the left ventricle is in systole and when the mitral valve is closed, because it's getting the pulmonary venous flow back and it's getting filled with the mitral valve being closed. During ventricular systole, eventually the aortic valve will open and you'll get ejection of blood flow. So this, already in this view, it's important to see that the valves are opening and closing, because if you don't get an opening or a closure of a valve, it may inform you that either there's an anatomical problem with the valve or that the ventricle is just not able to eject or fill because of issues with its performance, for example, either systolic or diastolic. On most machine and images, you'll get also information about the type of probes that you're using. So typically, these are the hertz. The lowest hertz are for typically bigger patients, because lowest hertz or lowest frequency will have ultrasound going deeper into the chest, versus if you had a baby, you would probably be closer to like 10 or 12 megahertz, because you don't need to go so deep into the chest. And with higher frequency, you get more resolution and more information back on your ultrasound probe. You also get what we call the frame per second, which means how many image you're accumulating in 1 second, which informs you on the granularity of the temporal resolution. So like if you're going to the cinema, the more you get frame per second, the more smooth you see the movie. And it's the same thing with echo. And this variable will change depending on how you optimize your image. Because if you're asking the machine to get more information, this frame per second will go down because it has to put more information in getting, like, for example, a larger width. So typically more narrowed, with a depth that is adjusted to its minimum, will obviously provide you with more capacity to get more frame per second. And so that's why we try to always optimize the image and not lose a lot of acoustic power when we're obtaining the image with areas that we're not necessarily interested in kind of querying. The other things that we can see on this image is here the heart rate for this particular patient and the ECG tracing. We know that the QRS often falls when we are at the peak of diastole, and then eventually systole, or the peak of contraction, will typically appear in that area, and then eventually you get relaxation and then you get full diastole back at the onset of the QRS just before activation or the electromechanical activation. Here we can kind of have a sense that the descending aorta is here. It's actually seen in cross section, so it's a view from on top, like if you took the actual aorta and you cut it in the middle and you're looking at it as if it is a circle from on top view. When you angulate your probe more posteriorly, at this point, you can see more the RV with the inflow portion of the RV, and you can see some of the three leaflets of the tricuspid valve. Here we see the posterior and the anterior leaflet of the tricuspid valve in this particular view. We can see the right atrium. We can see the inferior vena cava with what we call a eustachian valve, which is kind of a redundancy of tissue from embryogenesis. And it's sometimes a good view to appreciate if there's a line that's misplaced, although one view is not enough because sometimes you can get mirroring artifact and the catheter may appear like if it is in the atrium in this view. And actually, when you do a subcostal, you see that its tip is at the right position and it was just artifactual. So that's why it's very important that you always confirm in multiple views. And so to obtain this view, you typically will angulate more posteriorly. So the movement of the probe, if it's closer to kind of the chest like this or closer to the chest like this, it will cut structures that are more anterior versus as you're going more perpendicular to the chest, you're going more towards the back of the chest. And so the back of the chest is here, and here we see our RV portion of our RV inflow or inlet, and then the right atrium. Just before I forget, this view is kind of good view already to appreciate also globally the left ventricular function, because we can see the two part of the LV wall, the interventricular septum and the posterior wall kind of get closer to each other, which informs us that there's relatively good function, at least at that area. It doesn't inform us for like kind of the apical area. So that's why sometimes we'll actually move the probe going towards the apex of the heart, so towards the left or the nipple, in order to see more the motion of the posterior wall and of the interventricular septum at the apex, especially if you're more of in the cardiology field and you want to rule out presence of a ventricular septal defect, you need to put what we call color and really scan the septum along its entire length and in multiple views, because the septum is like a 3D structure. It's not just like a line. When you angulate more anteriorly, you're now entering the outflow tract of the right ventricle. And so typically the RV looks like a long banana. So the banana goes from the back to the front. The front portion is the outflow tract. The back portion is the inlet. And so you get blood flow going like this and going towards the outflow tract like this. And that's why there's no continuity between your pulmonary valve and your tricuspid valve. They're kind of on two different planes and they're not touching each other. That's very different than in this view where you see that the aortic valve is kind of almost touching the mitral valve annulus. They're in what we call fibrous continuity. So here we see the pulmonary valve, which has 3 leaflets, but in here we see only 2 of its leaflets. And we can see these kind of very thin walled leaflet opening and closing. And so that's a good view to appreciate if the pulmonary valve is opening and closing. And in a more advanced application, if we put color over it, which indicates blood flow directionality, you may see blood flow originating before the valve and going through the valve. If you go through the website, there's many examples of that. So this is an example in a baby. How do I know this is a baby? Well, first of all, we're at a faster heart rate here. I can see kind of the QRS that's been cut in the bottom. I can see also that because of that, I'm able to get less depth. Each of these dots represent a centimeter from the probe. So you can see the difference from here, where here you have 10 centimeters. So this is a much bigger patient. And here you have like 1, 2, 3, 4, 5 centimeter in this particular patient. So it's a 5 centimeter heart. So it's likely like a term patient to have these hearts because preterm babies have smaller hearts than that. You can also see that in this particular context, we use the probe that is able to generate a frequency at around 8 megahertz, which is more than the 3 megahertz here, which was needed to achieve more depth. And so in this particular view, we can see a chunk of the septum, the RVOT, we can see the posterior wall, we can see the aortic valve, we can see the ascending aorta, the left atrium, and we can nicely see here the round descending aorta. This bright line represents the pericardial sac. The pericardium is a very echogenic structure, and so will appear more white. If you're not aware, anything that is dense and will reflect ultrasound will typically appear whiter on the screen, and anything that is not dense or does not reflect or does not rebound ultrasounds will appear dark, because the ultrasound beam is going through the tissue and then will bounce back on certain structure, go back to the probe, and the probe is actually listening to that echo that is happening from this bounce back, giving us a visual representation of this actually acoustic or wave phenomenon. So one thing that we can do in this view is that we can use what we call the line of interrogation, which is a line that we can position at the tip of the mitral valve leaflet. And we can ask the machine to really provide us a visual representation of everything that is happening along this line through time. We call this an M mode or motion mode, because we're able to visualize the motion of whatever is happening across this line over time. So you have time on the x-axis, and you actually have these like 5 centimeters. So 1, 2, 3, 4, 5, they're here. These are the 5 centimeters. So this is your scale. This patient is going at 128 beats per minute, and this particular echo was ECG gated. So you have the ECG on top. So we know that at the peak of diastole, that's when you typically have your QRS, and we can see it just from the image that we have the most significant diameter of the left ventricle. So if we follow the line from on top, you get the RV free wall, you eventually get the cavity of the right ventricle, the septum, the cavity of the left ventricle, and the posterior wall. So we can see it here. The first diameter is the RV anterior wall. Then you get your RV diameter, which is here in diastole. Then you get the septum in diastole, which is here. Then you get your LV diameter in diastole, and then you get your LV posterior wall diameter in diastole. Then you can obtain the same measurements in systole. And one of the advantage of these measurements is that it's an easy, quick measure of function by doing a fraction of what's happening in diastole and systole for the diameter of the left ventricle. In this context, we call this the fractional shortening or the shortening fraction. And so we would take the LV diameter, which is 1.67, subtract the LV diameter in systole, which is 1.08, and divide it by the diameter in diastole to give us a percentage of how much this diameter shortened in systole. One other very common element that people will look at in some of more of the pediatric emergency medicine cardiac POCUS field is something called the E-point separation. A very vigorous left ventricle will have a tendency to have the anterior mitral valve leaflet get closer to the septal wall during contraction. Not too close though, because if it's touching and blocking the outflow tract, we call this systolic anterior motion of the mitral valve, which is not a good thing, and it's more of an advanced application. But here you can see the two leaflets, and you can actually see the first anterior leaflet here, and here you can see the posterior leaflet, which is this one. Okay, and this anterior leaflet during contraction is getting very close to the septum here. You can see that it's kind of getting closer here. And so it informs you, well, this is actually during filling, but this E-point has been used in certain literature of the POCUS in emergency. We don't typically use that in the neonatal period as a marker of true cardiac function, to be honest. The problem with M mode is that it's very angle dependent. Like if I put my cursor here, if my image is not optimized to really be in front of the mitral valve tip leaflet. So it has been discouraged by the American Society of Echo, and they've been rather encouraging the use of the 2D in order to calculate the differences in the largest and shortest diameter. But the TNE guidelines are still using that as a marker of function, and I put the image from their publication. You can see the example where here actually they put the line, which is if you would have to put the line with the probe, the line would appear here. And here you can see that they've put their line, they translated the line that they added here to show that even this image is probably not the best angulation to obtain this curve via the motion mode. You can also do this in what we call the parasternal short axis view at the tip of its mitral valve in order to get the same M mode. So now we're doing a zoom on the outflow tract where we see 2 of the 3 leaflets of the aortic valve. We can use that to measure the left ventricular outflow tract diameter. This is particularly true if you have a tendency to calculate left ventricular output or estimate left ventricular output, which is more of a targeted neonatal echo application. This is the sweep from posterior and eventually anterior within a full curve, so within a full clip. So we start by seeing the long axis of the left ventricle, and eventually we start angulating posteriorly. And as you angulate posteriorly, you see more of that right atrium, inferior vena cava, tricuspid valve, and then the inlet of the right ventricle. Then you'll go back towards the long axis, and eventually as you go more anteriorly, you start seeing this RV outflow tract feeding into the pulmonary artery with this pulmonary valve in between. So here we see the pulmonary valve closed, but then here this is opened at the peak of systole again. And so we could use that to measure, for example, the RV outflow tract in systole if we were estimating the right ventricular output. Another example here of just the RVOT, RV outflow tract, the pulmonary valve, and the main pulmonary artery. And this is just to show you in parasternal long views how we can get in a baby. And I know it's a baby because it's a 12 megahertz probe, the aortic valve and the pulmonary valve and how they would look like. And as you can see, they're really not oriented in the same direction. They're actually almost at 90 degrees of each other. And if obviously we would have something like a transposition of great arteries, it would be quite different. They would be parallel to each other. So here we can use color. The principle of color is that we have a color box, and this color box informs us on the direction of the blood flow. So you have the probe here, and whatever is going to be blue will be away from the probe, and whatever is going to be red will be towards the probe. So in this context, we can see that blood flow originates before the valve, crosses through the valve, and feeds the pulmonary artery. It's important to see that it starts before the valve and that actually you don't get blood flow coming from another source. And that really it's originating from the RV outflow tract. So we can see it if we go slow motion, originating before the valve and eventually crossing the valve. In this particular clip, you can see here that there's a bit of redness, and that's not because blood flow is coming back towards the probe. It's because we get a phenomenon that's called aliasing. What is aliasing is that the different blood flow going here are quite turbulent, and they may be swirling, or they may go in different directions, which means that the machine at this point has difficulty capturing the true directionality of the bulk of the blood flow. So typically when we put color boxes, we have a scale. The scale of the baseline means that it's neither going towards or away from the probe, or there's no blood flow. And as it's going towards this side, it means it's going red, it's going towards your probe. And as it's going away, it's going to be blue. And the color code provides you a scale of the velocity of this blood flow. This scale is currently calibrated at 0.79 milliliters per second, which means that anything that is below this number, if there's a blood flow going at 0.6 meters per second, the machine has been instructed to filter it out, to not show it to you. So typically, if you have arterial flows, high velocity flows, aorta, blood flow going through like a stenosis, blood flow going through atrioventricular insufficiency, we'll typically use higher velocity filter, or sometimes we call it the Nyquist, in order to really truly see this high velocity flow, and without getting like the machine being confused about the directionality of where the flow is going. if we're starting to see low velocity blood flow, so think about a venous flow, a flow through a PFO, a patent foramen ovale or interatrial shunt, a flow through a coronary, and that's more for like cardiology or TNE application, we would use like a much lower velocity filter in order to see that flow. The lower the velocity that you go, the more you don't filter out blood flow that goes in different direction, and more you may get aliasing in certain structures because the machine has difficulty to really get you the bulk of what is actually the main directionality of the blood flow. Sometimes you may have structure that you will use higher or lower Nyquist. For example, if you have ventricular septal defects in the first few days of life, we know that the pulmonary vascular resistance and systemic vascular resistance are still quite similar. And so during systole, the blood flow going through that VSD may be, minimal or at very low velocity. And so you may need to have very low Nyquist in order to pick up these kinds of VSD. As these babies will grow and their PVR are going to fall, then you may not need to have low Nyquist or no low velocity filter. You may need a higher velocity filter to really and to see the actual directionality of this ventricular septal defect. And these concepts apply also for a PDA, for example. If you have a large PDA that is unrestrictive, the velocities of equalization would be at very low velocity. So you may need a lower Nyquist to actually see the bulk of the directionality. So now we'll go to parasternal short axis. We've accumulated a lot of concepts already since the beginning of this recording. So you can see here that the baby for the parasternal short axis is really almost a 90-degree, or not almost, it's actually a 90-degree from the perfect long axis. So this time the marker is typically towards the left shoulder. And in many of the tinier babies, it's actually much higher up. It's almost close to the suprasternal area, because I see a lot of people actually going very close to the nipple line, and you just don't get a short axis, or you'll falsely get what you think is a short axis with septal flattening. It's actually because you're too low into the chest and you're not getting the perfect image. And so in these images, what we're going to get or appreciate, obviously, again, the cardiac function. It's a good view to sometimes detect if there's like a pericardial effusion, although the best view is typically the subcostal one. You'll also have a sense of the relationship between the RV and the LV, and really the short axis images, either obtained from the parasternal views or the short axis of the subcostal view, are typically the only ones where you can appreciate what we call the septal motion. Don't try to, get an estimate of PA pressure relative to LV pressure from like an apical view. It's not good practice, and it will misinform actually your evaluation. So here we have, again, the RV free wall, the right ventricle, the RV cavity, you have the interventricular septum, and then you have here the left ventricle with the two leaflets of the mitral valve. So you have the anterior and posterior leaflet, and we can actually see the opening of the mitral valve as in this diagram. And as you go lower into the LV cavity, you start seeing the attachment of this mitral valve, which are the two papillary muscle that will eventually come and connect to your posterior wall as you go down towards the apex. And so you get what we call a posterior medial papillary muscle and an anterior lateral papillary muscle. Why medial? Because the sternum is here. And so as you're getting closer to this side, you get closer to the medial side of the body. And as you're going towards the marker, you're going more to the lateral side of the body. If you see, the marker is oriented towards the lateral side of the body and towards the left side of the body. So this is the left part of the left ventricle, and this is kind of the right part of the right ventricle, and this is the right ventricle. Or I should say more posterior or inferior part of the left ventricle to be fully truthful. So here you can see the probe, and you can see how you can cut by orienting your probe in different orientation. And so as you're getting closer to the neck, you're going to start seeing, more of your C and B. So we can see that the C is more RV outflow tract, pulmonary valve, pulmonary artery with the right and left pulmonary artery, or B being your aortic valve that is trileaflet. Often we call it the Mercedes sign because it has this kind of Mercedes logo. You can see coronary artery, so the left and the right coronary artery. You can still sometimes see a bit of the pulmonary artery with the pulmonary valve, but you start seeing your tricuspid valve, your right atrium and left atrium. Not the greatest view to see the interatrial septum because we're often parallel to its course. So the best views are typically the subcostal views. And as you get to the base of the heart is where you see your kind of nice trileaflet aortic valve. You get the left atrium in the background. And so this is a good view to measure the aortic valve to left atrial diameter in order to get a sense of how your LA might be dilated relative to your aortic valve. Although sometimes your aortic valve could be the part that is small compared to your left atrium. And I'm talking about the marker that's called the LA on aorta ratio. And there's more on that if you go into the PDA section of the website. As you go more down, then you start seeing your D section, which is here, where you have your mitral valve, your interventricular septum, your posterior wall, and your RV. And then you finally get into the mid-papillary area where you have these two papillary muscle connecting to the posterior wall, the interventricular septum, and the right ventricle, which looks like a crescent, and typically will hug your LV. And that's true only when your RV pressure is lower than your LV pressure. If your RV pressure is equal or higher than your LV pressure, you'll start seeing some septal flattening or even bowing of your septum. And then when you see that, then you have to reflect, well, is my RV that is hypertensive, my LV that is hypotensive, a mix of both, or maybe both of them are hypertensive, but the RV is much worse than the LV. So then you have to put in relationship of what's happening into the systemic compartment. So this is the parasternal short axis view. You have the RV on top. You see this pulmonary valve opening and closing with its thin leaflet and a bit of the main pulmonary artery. We can see the trileaflet aortic valve, and really you have to observe as it opens to decide if there's fusion or if it's a bicuspid aortic valve, and that's more for our friends in cardiology who do congenital heart defect assessments. And then you have the left atrium in posteriorly. So here you have your probe, and then so this is more posterior. And so you see the left atrium and then the right atrium, and then between the right atrium and the RV, you see the tricuspid valve. This is coming a bit higher into the chest where you see the whole course of your pulmonary or main pulmonary artery dividing into the right and left pulmonary artery with kind of the beginning of your ascending aorta. Here it's a view where we're focusing more in the parasternal view into the right ventricle. So you have the right ventricle here, the aortic valve, and you have some of the leaflets. So this time you have what we call septal leaflet and anterior leaflet of the tricuspid valve with the RA and a bit of the left atrium here. When we go down below the base of the heart, the left atrium sits on top of this left ventricle. So basically we're looking like if we're at the bottom of the left atrium. So on top of this image, there is the left atrium kind of emptying into the left ventricle. So we see here the mitral valve that looks like a fish mouth opening and closing. And we have the anterior and posterior leaflet of the mitral valve. You have the interventricular septum and the RV on top. This is not yet the best view to appreciate the relationship between the RV and the LV pressures using the septal motion. It's really in the view of the papillary muscle that you can appreciate that. So we have here the posterior medial and the anterior lateral papillary muscle of the mitral valve. Let's skip this. So this is an example in a baby where you see nicely this fish mouth. You see the interventricular septum and you see the RV free wall with the RV diameter. And this is with the schematic representation. And as you go a bit lower, now this time you're going to be able to see the papillary muscles. So if I pause it, you can see your two papillary muscle, your septum, your RV, and your posterior wall. Septal flattening for information on what's happening into the corresponding outflow tract or grade vessels is really has to be at the peak of systole, because at the peak of systole is when you have your pulmonary valve and your aortic valve that are open. And so when they're open, they're equalizing pressure with the underlying ventricle. So at the peak of systole, you can assume that the relationship between the RV systole and LV systolic pressure will be the same as the relationship between the pulmonary artery and the aortic pressure. And so here we can see that we have a nice round left ventricle and more of this crescenting, small, thin right ventricle, which informs us that the LV systolic pressure is higher than the RV systolic pressure. Diastole, the aortic valve and pulmonary valve are closed. So the septal motion only informs you on the end diastolic pressure, and you would start seeing septal flattening if you have, for example, severe RV dysfunction where you get very high residual RV volume at the peak of diastole, or in situation where you get too much RV filling, such as vein of Galen malformation, hepatic AV malformation. And for interatrial shunts that are left to right, usually not in the first year of life. It's really after 1 year of life where you start seeing that you get flattening of your septum in diastole because you get overloaded RV. In the first year of life, you don't really see that even if you have a big ASD shunt typically, although there might be exceptional circumstances, but definitely not during the neonatal life. So here, this is an example where you can see in systole that you get flattening of the septum because this RV is probably hypertensive regarding the LV. And you can see in this particular case that the RV looks quite dilated compared to the LV and has quite hypertrophy of its muscle wall. So that was an example of septal kind of bowing. Here, it's an entire sweep where you go from the actual mitral valve here, and as you go down towards the papillary muscle, so as you go and sweep towards the papillary muscle, so you can see the two papillary muscle, and eventually you actually reach the apex where you can see that these two papillary muscle are attaching to the free wall or the posterior wall of the left ventricle. The mitral valve will not attach to the septum, and that's one thing that is unique to the left ventricle. Same thing, the RV will have a tricuspid attachment typically to the septum. We can even appreciate what we call the moderator band, which is this band that connects the free wall of the right ventricle to the septum and which defines the right ventricle. So as you get increasing RV afterload, you may eventually see these kinds of images where you get a very dilated RV and septum that kind of almost pancakes or obliterate the cavity of the left ventricle. We're now in the apical views, which is a good view to obtain information on function of the RV and the LV. So typically in the apical four-chamber, the schematic has the right atrium, left atrium, RV, and LV, and that's why we call it a four-chamber. And you may see these papillary muscle connecting to the left ventricle posterior wall, free wall. You can see the septum in between the RV and the LV, and you can see the RV free wall as well. You see the tricuspid valve, the mitral valve. And what we see here is the anterior and septal leaflet of the tricuspid and anterior and posterior leaflet of the mitral valve. And you get sometimes a sense of the descending aorta. You may also see some of the pulmonary veins connect to the left atrium. So as you can see, the probe here will have the marker towards the left of the patient. And it's really at the apex. So the LV is kind of here. And so you're looking from the bottom. And then by convention, at least in pediatric, we flip our pie of imaging. That's not true in the adult world and sometimes in some of the POCUS textbook, but in the conventional targeted neonatal echo or pediatric echo, at least in North America, we'll have a tendency to flip to get more of an anatomical view. And so the rule of thumb is that typically when the tail of the probe is below the nipple line, or that you're looking from the bottom, so in the apical and subcostal view, we'll flip our pie, and whatever is above the nipple line, you tend to have the pie the other way around because the tail is towards the head. So you can see your cursor here and facing your left ventricle, which the left ventricle is closer to the lateral side of the body. In this particular patient, you can see that the probe is almost on the nipple. In many babies, it's actually even at the anterior axillary lines, and see many people putting the probe on the nipple. And I always tell them actually go more towards the anterior axillary line, or even medial axillary line. So in most baby, actually, the probe would be brought towards the back, actually, to get a nice apical view. And so in the apical view, we can do a sweep from anterior to posterior. And so from anterior posterior, we would see initially in the mid zone, we would see that typical four-chamber view with the pulmonary veins. As you go more posteriorly, so in the D, you can see the RV, the LV, and the RA, but you actually see the coronary sinus draining the coronary system into the right atrium. And as you're getting more anteriorly, you can actually see more of the LV outflow tract. And eventually, if you go even anterior, in some patient, you can appreciate a bit of the RV outflow tract. This probe can be turned at 90 degrees. And if you're going 90 degrees this time, you're cutting through the anterior and the posterior walls of whatever structure you're going to look at. So you can look at the LV, or you can look actually at the RV. And here we're looking more at the LV for this diagram, where you get so you have anterior, posterior, and then you have superior, inferior. And so you can see that the anterior portion of the LV is here, posterior portion of the LV is here. We call this a two-chamber view because you see only the left and the atrium and the left ventricle. In my images, it's actually going to be a bit flipped. Sorry to confuse you. The anterior portion will be here and the posterior portion will be here. So you can see that the cursor could be turned 90 degrees with its marker towards the chin or with its marker towards the back. So either the marker here could be the chin or the marker could be here towards the back. In this particular context, the marker is kind of towards the back. And that's why we have first, if we have the probe here, you have the anterior and posterior portion. So this is just another schematic of that. And we'll talk about the 5-chamber view, where sometimes you need to actually do a little rotation by 30 to 45 degrees in order to see the LV and outflow tract. Oh, I'm going to skip this. So this is a typical 4-chamber view where you have your right atrium, right ventricle, left atrium, left ventricle. The past few slides were just describing the right and left ventricular function. So typically the RV will function like as a longitudinal function. So its contraction, as you can see in 3D, is most powerful along the longitudinal axis to kind of propulsate blood flow towards the outflow tract. The LV has more of a contraction towards the inside with a certain portion of rotation. So a lot of the markers of function are trying to appreciate how it's contracting towards the inside rather than its longitudinal contraction. So this is an example of a 4-chamber and 2-chamber view. So in this 2-chamber view, you can see the cursor, and the cursor is marking your anterior wall. And so here you have your posterior wall and your liver. In the 4-chamber view, you have your right and left atrium, right and left ventricle. You can see your tricuspid valve and your mitral valve. You can see the lateral wall of your RV, and you can see the anterolateral wall of the LV, and you can see the 2 mitral valve leaflet and 2 of the tricuspid valve leaflet with the septum in the middle. In this other view, you can see the posterior wall or inferior wall of the left ventricle and the anterior wall of the left ventricle. And it's a good practice to acquire these views because it informs you on really like the entire global function of your LV. And if you're doing more advanced metrics, like an ejection fraction using Simpson's biplane, you would need these 2 views in order to estimate the diastolic volumes and the systolic volumes. You can also see in the left atrium here that there's a little kind of pinky that's coming out. This is called the left atrial appendage, and it typically has a finger-like appearance versus the right atrial appendage that we don't see in this view is more of a pyramid. So here I'm putting color. I'm putting color over the tricuspid valve. I can see that there's blood flow filling in red, my tricuspid valve, and the blood is originating in the right atrium and going into the right ventricle. I can see a trace of little blue jet. This tells me that during the closure of the valve, there's blood flow going away from the probe, which is tricuspid insufficiency. I put the same color box into my mitral valve and I see the same. So I see blood flow filling my left ventricle. It's important to have this to make sure we're not facing like mitral stenosis or that the valve doesn't open. And you can see that there's a trace mitral insufficiency too, where there's this bit of blue jet when the valve is closed. This is, if you are in 2-chamber, and you take your probe and this time you you do a translation and you're looking at your RV, this time you're going to cut the anterior wall of your right ventricle and the posterior wall of your right ventricle. And the view that you're going to see is actually this view, where you have the posterior wall of the right ventricle and the anterior wall of the right ventricle. In comparison, in this view, you get the lateral and septal wall of the right ventricle. So it's like we're taking the image in 3D of the lateral and septum, and now we're switching and we're going anterior and posterior to see the other walls of this ventricle. And you can see here that you have the right atrium, the RV posterior wall or inferior wall, the anterior wall, and eventually you get this pulmonary valve and main pulmonary artery. So you see blood flow coming in and going out. And in the background, you can see kind of the aorta that is originating from like behind, because the aorta tends to originate from the middle of the heart. And we saw that in the parasternal short axis, if you remember well, where we saw that Mercedes sign actually coming from, sorry for going, from the middle of the heart. So remember, this is anterior pulmonary valve. So the pulmonary valve is more anterior. It's actually more to the left of the aortic valve, which is kind of central coming out. So if we would follow, it's coming out and then curving and giving our descending aorta. So if I go back to the apical view, it's a great view to assess function of your LV and your RV. And you can also obtain images, and this is a more advanced application, but you can get images of your anterior and posterior wall of your RV. And you can see also you can use some of these markers of what we call end diastolic area fractional area change. So you can do this equation in both the 4-chamber or 3-chamber, where you get the area of your RV in 3-chamber and systolic area in 3-chamber, and then get the fraction of that. Or you can also do it in the 4-chamber view and get the 4-chamber fractional area change. You can also get this view to see color filling your main pulmonary artery. If you take your probe and from the 4-chamber view and rotate clockwise about 30 to 45 degrees with a slightly more anterior angulation, you would see kind of what we call the 5-chamber view, where you have your LA, LV, aorta, RV, and then RA. And you can see the blood flow filling through the mitral valve and going inside your LVOT and aorta in this particular view. And this is a particular good view if you would estimate what we call left ventricular outflow tract, left ventricular output. Briefly, subcostal views. So the subcostal views are particularly important, and they're good to assess line placement, to look at your IVC, to look at your descending aorta for like umbilical arterial line, for example, and they're very good for pericardial effusion. So and if we would go in more advanced application, you would have to look there for what we call your situs. So to make sure that your IVC is on the right side as of the aorta and it's connected to the right atrium, and to make sure that there is an IVC and that it's not an absent IVC. Like in some of the heterotaxic syndrome for more of the cardiology application. And so typically the subcostal view is really, as it says, subcostal. So you have the costal margin and you would put your probe at the either subxiphoid area or a bit closer to the liver, because the liver is a very echogenic structure and it helps magnify or amplify your ultrasound transmission, which helps really with the imaging. So a lot of the cardiac views using the subcostal approach is actually more towards the right-sided of the abdomen, because you're using the liver to provide you with this important information. This is an example of the situs view where you see the IVC and the descending aorta. And so you have the IVC that is to the right of your descending aorta. Then you can turn 90-degree with the marker down and really have it linear, so that you elongate your descending aorta, so you can see all your descending the aorta with your diaphragm, and sometimes you can even see your celiac and superior mesenteric artery. And if you translate your probe as your longitudinal towards the right side of the abdomen, you start seeing your IVC emptying into your right atrium. You can also use this view. You can also then shift your probe and get what we call the short axis view. The short axis view, why? Because you get a short axis like in the parasternal short axis to get information on your SVC, IVC entering your right atrium, the relationship between the RA and the LA, and you can sometimes even appreciate the RA filling into the RV. So this This was the short axis. This is the long, it's written short, but it's actually the long axis. This is a mistake. I had corrected it, but this is probably old slides. In this short axis, in the long axis, why the long axis? Because the LV is along its long axis, as you can see. The marker is towards the, again, it's kind of parallel, the probe is parallel to the costal margin. And in here, you first start with the relationship between RA and LA, and it's great to get for interatrial shunting. And as you're going more anteriorly, you start seeing your RV-LV with outflow tract, and eventually your RV with its own outflow tract. Okay, we'll start with images. So this is a situs example where you see the IVC inside the liver, and you see the aorta. And the best practice is actually to do a sweep and see this IVC connect to the right atrium. And you can see that the aorta is on the left side and the IVC is on the right side inside the liver. Now we inverted the pie and we do a full sweep in the long axis view. So if I go towards the back, I can see my liver. I can see even my diaphragm, which is very bright. And I can see this IVC eventually connect into the right atrium. Eventually, I see more of my right atrium and left atrium. And eventually, I see kind of the interatrial septum, and I can see that there's a small communication that is likely a PFO. I can even see kind of the flap a bit of that PFO. And eventually, I get more anteriorly. I start seeing more the body of my LV with the aortic valve and the LV outflow tract. And you can even see this aortic valve open and close in the beginning of the ascending aorta. This is the ascending aorta here. And as I go even more anteriorly, I start seeing more of my RV. This is a portion of tricuspid valve. And as I'm going up, now I see my body of my right ventricle getting to the outflow tract, and I start seeing my pulmonary valve. And in this particular patient, I don't see well the pulmonary valve, but I can see the moderator band, which is kind of characteristic of the right ventricle. Oh, here I see the pulmonary valve. Opening and closing, opening and closing. Yeah, perfect. So this is just a view focusing on the atrium at the beginning, but towards the end of the clip, we get a sweep. So here we have, again, to reinforce right and left atrium with the interatrial wall. There's a small defect within this wall. And as we go more anteriorly, we actually see the superior vena cava entering the right atrium. And then eventually, as we go more anteriorly, we see this pulmonary valve with main pulmonary artery. This is the RV. In the background, before getting there, we had the aortic valve coming out of the LV. More anteriorly, I get the RV. And then I get up to the most anterior portion of the RV and LV. And then I go a bit back towards the mid portion. Here I put colors. So I see in red initially the SVC flow. So not here, here. This is the SVC flow, so going towards the probe. So SVC, the head, filling the right atrium. And eventually I even see a bit of that shunt that is red. So it's going towards the probe. So from the left atrium towards the right atrium. So it's a left to right shunt. And eventually I start seeing more of my left ventricle with the aortic valve. And I can even see filling of the ascending aorta. And at some point, you can even see kind of the two vessel crossing. I see in the background the main pulmonary artery, and here the aorta, and they're like almost 90 degrees. And as I get more anterior, now I see more of my RV feeding my right ventricular outflow tract. And then here, I actually scan the septum, and you can see that if you're more from the cardiology perspective, you don't go throughout the septum, you would miss towards the end as you go very anteriorly this communication, which is actually a ventricular septal defect, which is very anterior and closer to the apex, and it's here. It looks very small and it's muscular. I'm going to skip this view. So we did this already. This is another sweep from anterior to posterior and subcostal area. And now we're going to turn. We're going to turn the probe. This time, instead of like being parallel to the costal margin, we're going to go 90° to that. So we have the marker of the probes towards the feet and in the orientation like this, so towards the head and the feet. And then this time we have what we call the bicaval view. Why bicaval view? Because we see the SVC and we see kind of the IVC here running through the liver going into the right atrium. And what we see in the background is the left atrium. So this is a good view to see, for example, line placement and to see where it is positioned. So if you had a line coming from the bottom, so either a UVL or a PICC line, or if you had a PICC line in the arms or an ECMO cannula, you would be able to see it entering the right atrium or being at the SVC-RA or IVC-RA junction. And so we can see by color also that it fills the SVC towards the right atrium. And this particular view, you can appreciate that the frame is very low at 26, and that's because each time you add color, you reduce significantly the capacity of the machine to get a high frame rate. So this is an example of a sweep in this short axis view. Why short axis? Because it's a short axis of the left ventricle, which makes sense because it's 90° from the long axis. At the beginning, we get the SVC, RA, LA, and kind of the IVC that we see here a bit. It's probably collapsed because we're pressing on the abdomen, and IVC is typically a very collapsible structure in babies. So if you're pressing too much, it's going to collapse. We can also appreciate a bit the spine. And the spine sometimes will have the aorta running along its course. We can even see it here, part of the descending aorta running along its course. And so as I'm going towards the apex of the LV, so think of your probe going like this and going towards the apex of the LV, so more laterally of the patient, you will start seeing more of the structures of the heart. So first, you start seeing more of this tricuspid valve filling the right ventricle. Eventually, you start seeing the aorta that comes out in the middle of the heart, as we said, and coming out the LV, which you will appreciate better in a second. Now this is the LV, and you can see the septum, the RV free wall, the outflow tract of the RV, and then the main pulmonary artery here. Great view to make sure there's no RV outflow tract obstruction. Actually, one of the best view for that. And so eventually you can see the two papillary muscle, and you can see that you have a nice round LV. We can see a bit the gastric bubble too. And eventually you go more anteriorly for this patient. Here with color, so we can scan through the septum, and towards the end, you can appreciate there's a bit of a communication, which is a VSD. So it's the same patient with this small muscular VSD that is here. But as you go posteriorly, you see blood flow filling your main RV outflow tract and pulmonary artery. And if you go more posteriorly, you see the relationship between, you see your SVC here and then the IVC here. And it's blue normally because you get blood flow going away from RuPo and filling into your right atrium. Good view to appreciate the directionality of interatrial shunting if you're doing more advanced application. So if it's like this, it's left to right. So blood flow going towards the probe, left to right. If it's blue and red, it's bidirectional. And if it's completely blue, it's going away from the probe and it's going from the right to left atrium. We can use these views to measure the interatrial shunt, but that's for more advanced application. So these are examples where you see the catheter. So this is a catheter in the SVC and the long axis where you see actually that this patient has a very dilated subhepatic veins and very dilated IVC. There may be like RV dysfunction. This I think is a ECMO cannula if I'm not wrong. And so typically we like to have the VV ECMO cannula facing a bit of the inflow of the RV to avoid recirculation. And so it's a great way to kind of target the positioning. In this case, you can see a PICC line going through your IVC and entering your right atrium and being maybe a bit too far into the right atrium. In this view, you see the spine and you see the aorta running along it, and you see two white bright lines, and this is an umbilical arterial line. And in this view, you can see kind of as you sweep, you can see a catheter kind of flicker coming from the IVC and entering your right atrium. So I'll go through the suprasternal view quickly. This is at the level of the suprasternal notch, and it's typically more towards the right side or right shoulder. If you have an aorta that is going towards the left, so a left arch. And then in this view, you'll see typically nicely your arch view. It's less of a point of care ultrasound, but more of a TME or cardiac echo. And if you translate your probe or if you sweep your probe, you may get also a nice view to see your ductus arteriosus. If instead of using the longitudinal, the probe in the longitudinal axis, so with the marker towards the head of the baby, you turn it 90 degrees and instead being almost parallel to the clavicular line, you would see more of these views that are the short axis of the suprasternal view where you see your main pulmonary artery, RPA and LPA. So this is an example of the classical suprasternal view where you have your marker towards the chin. And in this view, you will see kind of your aorta that looks like a sugar cane and has 3 branching vessels. So number 1, number 2, number 3, brachiocephalic trunk, the carotid and subclavian arteries for the left side of the body. And typically this brachiocephalic trunk will then separate into the right-sided carotid and right-sided subclavian towards the right shoulder, which is one of the techniques we use to see when we look at the separation of the vessel of the brachiocephalic trunk. It informs us on the orientation of the arch. And so you can use this view to make sure there's no like dramatic obstruction that could explain, for example, significant LV dysfunction, but that's really more for advanced practitioners like pediatric cardiologists. And so that's an example where you see this sugar cane. In the middle, we transect the right pulmonary artery. We see the ascending, transverse, and descending arch. And what we call the isthmus is typically the zone where the PDA will connect. And it's this zone here. It's this little zone here. And in coarctation, we often also get what we call a posterior shelf, which looks like almost like a triangle of constriction for coarctation. So this is an example of a nice arch where the color flow is very laminar and we don't see any obstruction, versus in patients with coarctation where we see that there is this kind of posterior shelf that creates this very narrowed pathway for blood flow in patients with coarctation. And you can even see that there's another source of blood flow feeding the descending aorta. In this case, it's the PDA. This is an example of the branching of what I was talking about. So the branching in this particular view is done in a short axis where we're transecting the aorta in its short axis. So you can see the aorta here, and the first vessel that we will be given off is here. And eventually this vessel will divide in 2, 1 and 2 as you're sweeping towards the right shoulder. Much more advanced application, not cardiac POCUS, something more for the cardiologists. You can use this view also, the short axis, if you're angulating more anteriorly, so more towards the skin, to get something called a crab view, which is a view of the pulmonary veins. And you can see and appreciate here that because it's a venous flow, we go towards a much lower Nyquist. And you can see here the right-sided pulmonary veins, 1 and 2, and the left-sided pulmonary vein, 1 and 2. So we have the upper veins and the lower veins that are draining into the left atrium. Another example here, 1, 2, 3, and then 4. Here, there's a much higher Nyquist, and this is because it's a patient who had significant pulmonary overcirculation. It's a baby with transposition of great arteries and a large left to right shunt at the ductal level. And so it explains why there's high pulmonary venous flow velocities that we can appreciate at even a very high velocity filter. You can also use this view if you translate your probe to see what we call the main pulmonary artery. This is more advanced application where instead of being more central, you would then go more towards the left side of the chest of the patient where the pulmonary artery are coming off and bifurcating. And we call it sometimes the mustache view or the pants view, where you have the right pulmonary artery and left pulmonary artery, as well as the main pulmonary artery at its trunk. And this is when you put color and you see the 2 pulmonary artery being filled. I think assessment of the duct is a much advanced application. I just wanted to show what a left to right shunt looks like. The ductal view is a bit of a modification of the parasternal short axis view, and as well as that pence view that I just shown. Many of the babies also, the best view is actually the suprasternal area to see the PDA. And typically what you see in the PDA view is that you see the main pulmonary artery, the descending aorta, and you see a vessel connect between this main pulmonary artery and the aorta, where you can follow its track. And this provides you the information on directionality and size of this duct. So I'm not going to go into more detail of the PDA view, but there's a whole PDA section on the website, as well as a whole video dedicated to how to do PDA assessments. Perfect. So this is the end of this particular recording. Hopefully this gives you a sense of common basic point of care ultrasound views. Thank you for your attention. And this particular talk will be translated in Thai this time by my colleague here. And so this material will be available on the web for pre-workshop preparation. Have a great day. Thank you for your attention.